Hello and welcome. We will start from where we left in the last part. Let's start. The learning objectives are shown. Please take a look. Okay, now let's talk about the drugs which are more commonly used because insulin resistance is more common and so is the use of oral drugs to treat that type of diabetes. Type 2 diabetes is significantly more common than type 1. Accounting for about 90% to 95% of all diagnosed cases of diabetes. Type 1 diabetes is less common, affecting approximately 5% to 10% of people with diabetes. While type 1 requires insulin therapy to start with, type 2 has many therapeutic options, as we will discuss, one of which is insulin if required. The major issue is usually insulin resistance signals from adipose tissue due to obesity. Lifestyle changes play a crucial role in the treatment for the obvious reasons. Drug therapy comprises of drugs to increase sensitivity to circulating insulin and decrease in any factor that may lead to hyperglycemia, as shown here. You can pause the video and carefully explore. Several categories of glucose-lowering agents are available for patients with type 2 diabetes. Agents that bind to the sulfonylurea receptor and stimulate insulin secretion, sulfonylureas, meglitinides, and D-phenylalanine derivatives, and agents that mimic incretin effect or prolong incretin action. GLP-1 receptor agonists, dipeptide L-peptidase 4, DPP-4, inhibitors, and agents that mimic amylin effect. These all increase the secretion of endogenous insulin, hence they are called secretagogues. The pancreatic reserve is an important limiting factor in therapeutic success, and all may cause hypoglycemia. Except two groups as shown, the rest are called oral hypoglycemic drugs. More commonly, we use drugs which decrease insulin resistance but do not necessarily cause hypoglycemia. They are euglycemics and include agents that lower glucose levels by their actions on liver, muscle, and adipose tissue, biguanides, thiazolidinediones. They are usually the first drugs to be prescribed in type 2 diabetes. In addition, we can also use drugs which basically increase glucose loss by inhibiting intestinal absorption or promoting renal glucose excretion. These include agents that inhibit the reabsorption of glucose in the kidney, sodium glucose co-transporter inhibitors, SGLTs, and agents that principally slow the intestinal absorption of glucose, alpha-glucosidase inhibitors. The sulfonylureas bind to a high-affinity sulfonylurea receptor that is associated with a beta cell inward rectifier ATP-sensitive potassium channel as shown. Binding of a sulfonylurea inhibits the efflux of potassium ions through the channel and results in depolarization. Depolarization opens a voltage-gated calcium channel and results in calcium influx and the release of preformed insulin. Sulfonylureas can be divided into two generations which are compared in this slide in a self-explanatory manner. The second-generation sulfonylureas such as gliburide, glipizide, and especially glimepiride are used more often among the group. Glimepiride achieves blood glucose lowering with the lowest dosage of any sulfonylurea compound. A single daily dose of 1 mg has been shown to be effective. All sulfonylureas can cause hypoglycemia. Idiosyncratic reactions are rare, with skin rashes or hematologic toxicity, leukopenia, thrombocytopenia. Pause the video and explore the differences. Repaglinide is the first member of the meglitinide group of insulin secretagogues. These drugs modulate beta cell insulin release by regulating potassium efflux through the potassium channels previously discussed. There is overlap with the sulfonylureas in their molecular sites of action because the meglitinides have two binding sites in common with the sulfonylureas and one unique binding site. Repaglinide has a fast onset of action, with a peak concentration and peak effect within approximately 1 hour after ingestion, and hence indicated for use in controlling postprandial glucose excursions. The drug should be taken just before each meal. Hypoglycemia is a risk if the meal is delayed or skipped or contains inadequate carbohydrate. It can be used in patients with renal impairment and in the elderly. It can also be given if patient has sulfonylurea allergy. Nataglinide, a D-phenylalanine derivative, stimulates rapid and transient release of insulin from beta cells through closure of the ATP-sensitive K+ channel. It is absorbed within 20 minutes after oral administration with a time to peak concentration of less than 1 hour. For the same reason, it is useful to control postprandial rise in glucose. Hypoglycemia is the main adverse effect. It can be used in patients with renal impairment and in the elderly. An oral glucose load provokes a higher insulin response compared with an equivalent dose of glucose given intravenously. This is because the oral glucose causes a release of gut hormones, incretins, principally GLP-1 and glucose-dependent insulinotropic peptide, GIP, that amplify the glucose-induced insulin secretion. In addition, GLP-1 has a number of other biologic effects. It suppresses glucagon secretion, delays gastric emptying, reduces hunger and reduces apoptosis of human islets in culture. GLP-1 is rapidly degraded by dipeptide L-peptidase 4, DPP4, and by other enzymes such as endopeptidase 24.11 and is also cleared by the kidney. The native peptide therefore cannot be used therapeutically. One approach to this problem has been to develop metabolically stable analogues or derivatives of GLP-1 that are not subject to the same enzymatic degradation or renal clearance. One of them is a peptide derivative, exenatide injections as adjunctive therapy in persons with type 2 diabetes treated with metformin or metformin plus sulfonylureas who still have suboptimal glycemic control. Exenatide LAR is a once-weekly preparation. The major adverse effect is nausea, about 44% of users, which is dose-dependent and declines with time. Antibodies against exenatide may develop in many of these patients and attenuation of glycemic response has been seen. All of the GLP-1 receptor agonists may increase the risk of pancreatitis. Patients on these drugs should be counseled to seek immediate medical care if they experience unexplained persistent severe abdominal pain. Cases of renal impairment and acute renal injury have been reported in patients taking exenatide. Some of these patients had pre-existing kidney disease or other risk factors for renal injury. The GLP-1 effect is glucose-dependent in that the insulin release is more pronounced when glucose levels are elevated but less so when glucose levels are normal. For this reason, GLP-1 has a lower risk for hypoglycemia than the sulfonylureas. As mentioned previously, GLP-1 is rapidly degraded by dipeptide L-peptidase 4, DPP4. Sitagliptin has been studied as monotherapy and in combination with metformin, sulfonylureas, and thiazolidinediones. Therapy with sitagliptin has resulted in HbA1c reductions of 0.5 to 1.0%. Common adverse effects include nasopharyngitis, upper respiratory infections, and headaches. Hypoglycemia can occur when the drug is combined with insulin secretagogues or insulin. There have been post-marketing reports of acute pancreatitis, fatal and non-fatal, and severe allergic and hypersensitivity reactions. Saxagliptin may increase the risk of heart failure and hypersensitivity. Islet amyloid polypeptide, IAPP, amylin, is present in insulin secretory granules and secreted with insulin. It physiologically acts as a negative feedback on insulin secretion. At pharmacologic doses, IAPP reduces glucagon secretion, slows gastric emptying by a vagally mediated mechanism, and centrally decreases appetite. Pramlintide is an IAPP analog with substitutions of proline at positions 25, 28, and 29. These modifications make pramlintide soluble, non-self-aggregating, and suitable for pharmacologic use. Pramlintide is approved to reduce postprandial glucose spikes in insulin-treated type 1 and type 2 patients who are unable to achieve their target postprandial blood glucose levels. It is rapidly absorbed after subcutaneous injection, with peak levels occurring within 20 minutes, and the duration of action is approximately 2 hours. GLP-1 agonists are better than amylin analog in efficacy. Pramlintide should always be injected by itself using a separate syringe. It cannot be mixed with insulin. The major adverse effects of pramlintide are hypoglycemia and gastrointestinal symptoms, including nausea, vomiting, and anorexia. Since the drug slows gastric emptying, recovery from hypoglycemia can be problematic because of the delay in absorption of fast-acting carbohydrates. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!